afternoon. Thank you for being here. This is the session of the Hellenic Society for Surgery of the Hand, and it is going to be in Greek. No, actually, it's going to be in English, so don't worry. So there's a long tradition of exchange between the Greek and the French hand surgery societies, dating back to Guy Fouché and then later with Alain Gilbert and Caroline Leclerc, just to mention a few. We're building on that tradition, and in trying to honor this presentation, we have a lineup for this session of our newest generation of presidents in our societies. And let me briefly introduce them to you. So, starting from Athens, the first talk is going to be by Dr. Zagoreos on the clinical significance of surgical anatomy of the ulnar nerve, followed by Manos Pantridis, which is the current president of the society, on high ulnar nerve injuries, and following that, Philippos Giannoulis is going to discuss low ulnar nerve injuries. Both Manos and Philippos work in the largest public hand surgery unit in the country, so they have a lot of experience on those injuries. Then we are going to move further to the north, to Larissa. Professor Zoe Daliana is the first lady to ever become a professor in orthopedics in Greece and the first lady to ever become president of the Hellenic Association of Orthopedic Surgery this year. And she's going to discuss iatrogenic ulnar nerve injuries. And then we're going to move further to the north to Thessaloniki. Elada Papadogiorgou is a French-trained hand surgeon, and she's going to discuss the results of ulnar nerve repair and reconstruction. And after that, I am going to discuss the peripheral nerve transfers for the ulnar nerve and the immediate next president of the Hand Surgery Society. We were planning on one more talk, but unfortunately, coronavirus wasn't, didn't meet our plans. That would be on the principles of tendon transfers. So everybody has 5 more extra minutes. No, everybody has a couple of more minutes, so you don't have to speed up your talks. Just 2 small notes before I give the podium to the first presenter. The background of our presentations is a tribute to painter Yannis Moralis, a well-known Greek painter that loved France, and the French loved him back. And other than paintings, he did industrial design, and this is a design from one of his fabrics. Last but not least, none of this would be possible without the inspiration and the hard work of your President Didier FONTÈS. Didier, merci beaucoup. And as you know, behind every great president, there's always a great first lady. All right, so Nikos Zagoreos is going first. He's doing the anatomy of the ulnar nerve.
Good afternoon. I will speak about the clinical significance of the surgical anatomy of the ulnar nerve. I won't teach you the classical anatomy of the nerve. I'm sure that you have already known that from medical school. But we'll speak about the fascicular topography, the branching, and the number of actions in some cases. And this is based on on a recent article from Austria, from Vienna. The fascicular topography, the ulnar nerve as it exits from the axilla, it's actually the fascicular topography is not so distinct. It is based more or less on what Sutherland said, that it has a very complex interfascicular plexus. But this is the reason, and this is the basis what Oberlin actually used in order to do the Oberlin technique, which is in this form, and the modified technique has become a mainstay technique for the upper brachial plexus injuries. The fascicular topography of the ulnar nerve becomes more evident around the elbow. And if you look at the precondylar groove, you can see the nerve. It has the red. We have the motor fascicles. You can see the FCU fascicles and FCU, FTP, and the other side fascicles being more distinct. And the motor fascicle for the hand and the sensor being in more superficial area, more prone to pressure when it comes to problems in the precondylar groove. Going further down to the forearm, you can see that we have the branches. And the branches, this is a nice paper from Professor Leclerc and Nata Paulus. You can see it has the FDP and the FCU branches. The FCU is usually 2 to 4 branches. The FDP for the 4th and 5th finger are usually 1 to 2 branches. The important thing that you have to know is that all these branches are at the proximal half of the forearm. And one important thing is, if you look in the upper right corner, you can see the number of the motor units, motor fibers that you have in this nerve. Usually the FCU has, although they have pretty big numbers of fibers, like 1,430 on one case and 2,122 on the other case, it's only a few hundreds in both of them to be actually purely motor. Moving further down, you can see the fascicular topography of the ulnar nerve. The motor units, motor fibers are actually sandwiched between the two parts of the sensory fibers. One is for the volar side and one is for the dorsal side. And they move like this, with this kind of topography throughout the forearm. When we reach the lower part of the forearm, the dorsal cutaneous branch of the ulnar nerve becomes independent, and you can see it takes up the fiber, and what remains, the main trunk, is the motor fibers and the volar sensory fibers. And the dorsal cutaneous branch comes out in about 5 to 10 centimeters from the ulnar nerve. It goes around the ulnar styloid in a very peculiar and very variable fashion. This is a very nice picture from a Dutch article that you can see the variable positions of the dorsal cutaneous branch of the ulnar nerve. And the fascicular topography at that point is usually in this sense. You can see the volar side, the volar and more lateral, we have the sensory fibers, and in the motor and more deep area we have the motor fibers. And if you look at the numbers, the sensory has 21,345. That was the Boston article, which is very recent to 2023. If you look at the motor fibers, although it has the motor branch has total fibers about like 9,000, only 1,200 are actually motor fibers. And in Guillaume Canal, another French that actually introduced this area, you can see the superficial and the deep area, the deep branch. The superficial is on the left side with a solid arrow, with the dotted arrow is the motor branch that goes around the hook of the hamate. What you have to remember about that is that there are a lot of variations. This is a Canadian article that shows all the variations in the Guillaume Canal, and if you summarize them, you can see that they have problems with the bifurcation, the branching pattern. The bifurcation can happen in the canal, can happen proximal to the canal, you can have a trifurcation sometimes, you have problems, you can have variations in the deep branch, you can have variations in the superficial branch, or you can have even variations in the whole nerve, the nerve going through not the Guillaume Canal, but through the carpal tunnel canal. Very recent article, we actually tried to find the topography of the motor fibers within the motor branch in the Guillaume Canal. And if you can see that it's divided in 3 parts, the most medial part is the fibers that go, the motor fibers that go to the ductus disti minimi. The middle part is the fibers that go to the lumbricals, the interosseous, the ductus pollicis. And the most lateral one are the ones that go to the flexor pollicis brevis. So we covered more or less the basic anatomic topography and the number of actions, but we have the kind of patients, and this is the first patient that you have an ulnar nerve injury above the elbow with a gap of more than 15 centimeters, and you can see he had a normal intrinsic hand function. The second patient is a patient with another elbow injury with a high median nerve injury with a gap of more than 10 centimeters, and you can see she has some small motion even in the some muscles that are innervated by the median nerve, but the important thing is she has a sensation in all fingers. So based on what we've seen until now, how can we explain that? Are we lost, puzzled? The things that we have to know, and this is something that is described sometimes, that we have communication between the median nerve and the ulnar nerve. And this communication can be summarized in 2 of them in the forearm, the Martin Gruber and the Marinacci, and 2 of them in the hand, the Secagné and the Berrettini. The Martin Gruber is a communication that is usually motor fibers. It goes from the median to the ulnar nerve. It has a prevalence of about 20%, and it has many classifications. The classifications that most typically used, it has 3 types. There is one that throws fibers into hypothenar, the second one that sends fibers to the first dorsal interosseous, and the third one that sends fibers to the thenar. The most common one is the second type. And you can see here the connection. The second one is the Marinacci, the least actually described. It was described initially in 1964. It's also a motor one. It's a reverse. It's a reverse Martin Gruber because it goes from the ulnar nerve to the median nerve. Very low prevalence. And the third one is the one in the sequale, another French contribution. It's motor fibers. It's in the hand. It usually interconnects the deep branch of the ulnar nerve with the recurrent branch of the median nerve. It goes to the thinner muscles. You can have double innervation of the thinner muscles, or sometimes you can have an all ulnar hand with the innervation of the thinner muscles by the ulnar nerve. So you have to keep in mind that. The prevalence is pretty high, it's 55.5%, which is in one article where it's almost 100%. So you have to remember that. And this is a picture that you can show the interconnection between the ulnar nerve and the median nerve within the motor fibers. And the last one is the Berrettini. The Berrettini, actually, the name comes from the Italian painter Pietro Berrettini da Cortona, that he, well as other things that he, Baroque style, he painted these tabule anatomiche, which were published 1 year later, 100 years later, and they showed the interconnection between the median ulnar nerve in the hand. I'm sorry about the magnification of the picture, but you can see the interconnection here. So it has sensory fibers. The prevalence is pretty high. 61% is the most common prevalent, most common interconnection between the median and the ulnar nerve. And it has three types. The first type is between the ulnar nerve and the median nerve, which is the most common. The second one is between the ulnar nerve, the median nerve and the ulnar nerve. And the third one is between the two nerves, and they interconnect fibers. And if you see the prevalence of all these interconnections, you can see that these last two have pretty high numbers. So more or less, it's not any variance sometimes. It's the basic anatomy that we don't know and we haven't even covered. There are even communications between the radial nerve and the ulnar nerve in the dorsal side of the hand, which is also underreported. And you think in this very nice Brazilian anatomical study, you can see in 60% of the hands we have interconnections. So if you look at the PubMed and you go up on the and you put the ulnar nerve variations, you can see we have 616 results. If you put anatomic variations, it's almost 264. So it's a very high number for something that we already think that we know it from medical school. So do me a favor, when you have an ulnar nerve injury or you have a chronic ulnar nerve problem, always think that this is not might be the typical anatomy. You may have a variance which is pretty common. And for the ulnar nerve, and of course with that, we have a lot of physicians that contributed in understanding the physiology and anatomy. We have also from Greeks, and our contribution was also Fotinos Panas, a physician that came here many years ago in France, who was the first one to describe the cubital tunnel, and he's the father of ophthalmology here in France, and you can see his statue in Hotel Didier. Thank you very much.
Okay, thank you, Nick. Next up, Dr. Manos Andreidis is going to discuss the high ulnar nerve injuries.
Thank you very much. I think we're very proud as a country, as a society, to be part of this Congress. Thank you very much, everybody, for being here. So my topic is the high ulnar nerve injury. And if you see the literature, there's some confusion when you say proximal. What means proximal? But I saw some words like intermediate, lower, higher, but the truth is that the level on the proximal forearm where the ulnar nerve gives branches to the FCU and the FTP of the little ring finger, maybe I think this is the level that we have to speak and communicate each other, and above this level or proximal this level, we're talking about high ulnar nerve injury. So the causes could be non-traumatic, neurological tumors, chronic or vesicular, but this is not the subject of this round table. We're talking about trauma. So trauma can be penetrating, sharp, gunshots, fractures, complex fractures, or complex cases with fractures, and of course the blunt trauma, like we know in brachial plexus or other kind of closed trauma in upper limb. The muscles affected, you heard about anatomy before. The hypothenar muscles are affected, the two lubricals muscles, the ulnar one, all the interosseous, volar and dorsal, the adductor pollicis, the deep head of the flexor pollicis brevis is coming from the ulnar, so it's affected, the FDB of the little and ring finger, and the flexor capitularis. What about the sensory effect? The sensory is affected from the small finger, this is the nerve, the ulnar half of the ring finger, the ulnar palm of hypothenar with the palmar branches of the ulnar nerve, and the dorsal ulnar part of the hand, this is the dorsal cutaneous branch. Very nice, Nikos Agorias said about these variations, and these Berardini branch, they give some different sensory clinical examination. So you clinical examine your patient, you have different patterns, and this is due to the variations, and of course, also this motor branch of the multi-proven. And in patients with high ulnar injury, you can see some motor function or hand function will be preserved, and this is due to this anastomosis. So, high ulnar lesions, it's clear now that they do worse or they have worse outcome than the distal ones. And the reason is that the reinnervation, as a consequence of the time required for actions to reach the hand and the motor end plate, creates a degeneration. So there is not enough time for this distance for the actions to go again and reinnervate the small intrinsic muscles coming from the ulnar nerve. And this is the way we try to grasp something, to keep something. This is the normal sweep. There is a flexion of the metacarpal joint, and then we have flexion of the IV joint. But when we have high ulnar pulsi, the MC joint is in a hyperextended position. So the patient is trying to grasp something during IV flexion first, then he reaches the final position of the IV, and then starts the MCP flexion. So this creates an abnormal composite action and poor sweeping motion of the fingers. The claw hand, everybody knows the claw hand. What means claw hand for the youngest here? Inability to flex the MCP joints, inability to extend the IV joints. This is the Duchenne sign, and when we have claw hand, we need for the extrinsic flexors and extensors to work. This is why in high lesions, like in this topic, we have less claw hand deformity because we have the loss of FDB function. Of course, claw hand deformity, as you know, there are different patterns and depends also on these variations. In high ulnar injuries, we have dramatic loss of pinch, grip strength, and we have loss of thumb palm to index palm. This is the Froment sign. We have an activity, a hyperactivity of the flexor pollicis longus, or the gene signs in patients with laxity, where there is the thumb MCP hyperextension. And finally, the Waldberg sign is a very constant sign in high ulnar injuries. This is the abducted position of the little finger. This is coming because we have the loss of the palmar interosseous muscle, and the extensor digit diminuting is working unopposed. So pulls the little finger in an abducted position. So if we go in a repair, to repair the nerves in a high lesions like this, we do an end-to-end repair if we have no tension, or we do some tubes or grafts. But we know that all these outcomes, they are worst compared to radial and medial nerve, and there are some negative prognostic factors. One of them is the age. Older age, worse results, and the other is the level, higher level injury, worse results. So the nerve transfers came to our life the last 20 years, and the goal is to shorten the nerve regeneration path and to restore innervation of the intrinsic muscles of the hand before the severe muscle atrophy occurs. And this is some kind of configuration, this work coming from the United States and some other investigators about the transfer of anterior interosseous nerve to the deep portal branch of the ulnar nerve. There is also a talk about it. This one configuration is the end-to-end repair, and the other one is the end-to-side repair, the superside. And finally, when we lose the time for the nerve transfer, because we have to do it correctly and fast, and if we lose or we try to go for a hybrid treatment, we have the tendon transfers. The tendon transfers, they have goals for the claw deformity repair, for the thumb to index pinch, and finally the Waldberg sign. Thank you very much for your attention. And thank you for the
Right. So, next up is low ulnar nerve injuries. Dr. It's my next co-chairman. He's the next president of the Hellenic Society for Reconstructive Microsurgery.
Thank you very much for the kind and honored invitation, Professor Didier FONTÈS. I'm going to talk for the low ulnar nerve injury. The low ulnar nerve injuries, it is considered as the injury of the ulnar nerve affecting the ulnar nerve distally from the elbow. As Dr. Savoreo said so meticulously and so analytically, the ulnar nerve runs out when it exits out of the cubital tunnel. It runs to the forearm between the flexor carpi ulnaris muscles and the flexor digitorum profundum muscles. Then it goes into the Guillaume's canal. Here we can see the main trunk of the ulnar nerve and also the dorsal sensory nerve, the sensory nerve and the motor nerve after it exits from the Guillaume's canal, as we can see here in the diagrams. What about the low ulnar nerve injuries? The nerve is damaged distal to the motor branch of the FCU and motor branch to the FTP of the ring and little fingers. So in low injuries, the sensibility to the palmar ulnar hand is lost, and we have also the paralysis, usually to all 7 interosseous muscles, the ulnar 2 lubrical muscles, the 3 hypothenar muscles, the adductor pollicis, and also the deep head of the flexor pollicis brevis muscles. According to the center classification, when we have a nerve injury, it can be a neuropraxia, axonotmesis, or neurotmesis. The nerve repair, we have a primary nerve repair within the hours, the first hours after the nerve injury. The delayed primary repair within 5 to 7 days, and also secondary repair more than 7 days. The primary goal of the nerve repair is to guide the regenerating actions to the appropriate end organs and to restore normal sensory and/or motor function. In acute open ulnar nerve injury, the immediate exploration and primary neuropathy is recommended as long as the repair can be achieved under minimal tension. That's of very high importance. For contaminated wounds, on the other hand, for which immediate repair would be included, a delayed repair can be performed ideally in less than 72 hours, but up to 7 days without treatment of the outcome. Delays in repair increase the likelihood for nerve grafting, for neuron loss, and also for fibrosis of the distal stem. The primary nerve repair should be performed only if the wound is healthy and viable, the tissue bed is well perfused, the circulation is adequate, the skeletal stability and soft tissue coverage are present, and also tension-free repair is feasible. That's of very, very high importance. When we have to use a nerve grafting, the most common donor sites are solar nerve and also medial and lateral brachydactyly nerve to correct the low ulnar nerve injury. In a low ulnar nerve injury, the lesion of the ulnar nerve is at or near the wrist and the base of the palm, with resulting paralysis of hypothenar muscles, all interosseous muscles, half of the FPB, the palmaris brevis, and also the adductor pollicis. In patients with low ulnar nerve injury, some intrinsic muscles may be continued to function due to Martin-Gruber anastomose communication between the ulnar and medial nerve. What about the clinical presentation? With low ulnar nerve palsy, we have interosseous and 3rd and 4th lubricals are paralyzed, and also there will be loss of the hypothenar muscles, the interosseous muscles, the adductor pollicis, and the deep half of the FEP. There will be loss about 50 to 80% of the pinch strength, 50% loss of grip strength, loss of lateral deviation of fingers, and also loss of integration of the PIP and also MP joints. There are many clinical signs, such as the Fromen signs, the Duchenne signs, the Bardet sign, the Bouvier maneuver, and all the signs. As Manos Fandridi said, the Fromen signs will have when the patient is asked to abduct the thumb, such as holding a pencil in the web space, but the patient will instead hyperflex the IP joint to compensate the loss of the adductor. And also we have the clawing is present with low ulnar nerve injury, also known as Duchenne signs. The clawing of the ulnar 2 digits occurs to lesser degree. Long finger cannot be completely extended. That's because there is hyperextension of the MP joint because the unopposed action of the long extensors. And also we have the Bardet signs. In addition, approximately 50% of patients have median nerve cross-innervation to lubricants to ring finger, so we have prevented low deformity of the ring finger. What is the ulnar paradox? The ulnar paradox refers to the different manifestation of high ulnar nerve lesion at the elbow and the low ulnar nerve lesion at the wrist. In a high lesion, the clawing is paradoxically more mild than in a low lesion. That's because in the low lesion, the hand muscles are weak, but the long flexors which are supplied by the ulnar nerve just below the elbow are not affected. In the high lesion, both are weak and the clawing is more mild. The differential diagnosis, we have to diagnose from the rupture of the deep transfer metacarpal ligament, and also we have many treatment choices. When we have the adductor policy deficits, we can do a tendon transfer, or when we have the intrinsic muscle deficits, we can perform the Duke halter transfer. There are static procedures to correct the clawing, such as capsuloplasty, dorsal bone block, capsulodesis with pulley advancement or tenodesis, and also dynamic procedures. One of the most reliable and effective procedures to correct the claw deformity is the well-known Zancoli lasso procedure. What about the recovery? Prognostic factors that influenced motor or unsensory recovery and functional results were found in interval between trauma and reconstruction, injury level, worse results for proximal to distal, and mechanisms of injury, worse results for massive soft tissue injury to clear soft tissue injury. With a lower ulnar nerve injury, it must be treated, if it's possible, with primary repair. Low ulnar nerve palsy causes a complex disability that can be difficult to treat. Successful treatment depends on a thorough understanding of normal anatomy, the patient-specific functional deficit, and the individual needs of the patient. Also, a surgeon must tailor the selected tendon transfer to individual patient and should not apply the same transfer to every patient. Untreated low ulnar nerve palsy will lead to both deformity and disability. The full correction of the deformity, specifically clawing, can be accomplished by a variety of either static or dynamic procedures, as we said. The complete elimination of clawing is a reasonable goal, and also the disability in low ulnar nerve palsy, including weak pinch, weak grip, and asynchronous digital flexion, requires dynamic tendon transfers. Thank you very much.
So, next up are iatrogenic ulnar nerve injuries. Iatrogenic complications are a very delicate matter, so we always give it to the academics. Dr. Zoe Delilan is going to discuss.
Monsieur le Président, chers collègues, permettez-moi d'exprimer l'honneur particulier de notre présence aujourd'hui pour deux raisons. D'abord, car je suis le président de l'association Hellenic de chirurgie orthopédique et traumatologie. Ça représente tous les chirurgiens orthopédistes grecs. Et de l'autre côté, j'ai eu la chance, 20 ans auparavant, de recevoir le prix Raoul Tubiana dans le même congrès quand Dominique Levier était président. Now we'll continue in English. So, iatrogenic nerve injuries are relatively common injuries, and the spectrum of these injuries has changed in parallel with the technological advances in surgery. There are several nerves that may be injured iatrogenically, and among them, the ulnar nerve is usually injured in supracancular fracture surgeries. It has been found that direct surgical damage occurred in 94% of these iatrogenic nerve injuries, and in the upper extremity, the nerves more commonly affected are the radial nerve, followed by the median and the ulnar nerve. When we are dealing with these injuries, we have to focus on topography, etiology, the sequale and malpractice claims, and the prevention. So usually, these injuries are more pronounced around the elbow region, followed by the Lyons canal, and proximal sites and distal sites are rarely sites of these injuries. Concerning the etiology, we have to distinguish between the patient's positioning intraoperatively that can lead to such an injury, from injection injuries, and also from complications from close fracture reduction and surgical procedures. So we will start with intraoperative patient positioning, and we know that the ulnar nerve is very susceptible to these injuries and pressure as it passes through the superficial condylar groove at the elbow. It was found that the supinated arm position is likely to minimize pressure over the ulnar nerve. Also, in a study from the part of anesthesiology, it was found that peripheral nerve injuries represent 12% of general anesthesia malpractice claims, and 2/3 of them are peripheral nerve injuries from the ulnar nerve of the brachial plexus. Most commonly, these are found in procedures of cardiac surgery, neurosurgery, and orthopedic surgery. In spine surgery, it was found that the prone position will lead to compression or stress of the brachial plexus and the ulnar nerve. In cardiac surgery, it was found that the arm position, the asymmetric sternal retraction, will lead to compression of the ulnar nerve, and this is the case of a bypass surgery in a patient that was performed one month before, and you see the glowing and the necessity for an anterior transposition of the nerve. In orthopedic surgery, we can have this injury, especially during total hip arthroplasty, with percentage raising up to 6%, where the body position is tilted. And also, we can have these injuries during injection, especially for medial epicondylitis from steroid injections. What about complications of closed reduction? Most commonly, these occur during forearm fractures, and the risk of forearm fracture-related nerve injury is 0.7%. More than half of them are ulnar nerve injuries. The ulnar nerve may be entrapped within the fracture site or may be encased in hypertrophic scar tissue or bony callus. And this is an 11-year-old girl with a forearm fracture, closed fracture, that was treated 3 months before. Because it had no signs of progression of the nerve, we made an exploration of the nerve and we found that this was entrapped in between the fracture fragments, so we had to release the nerve and then perform the nerve grafting procedure. So, what about complications of surgical procedures? This can happen anywhere, but mostly around the elbow, and this includes arthroscopy, K-wire fixation, shoulder reduction term fixation, and carpal tunnel release. Shoulder arthroscopy is involved and it can lead to a ulnar nerve palsy, intermediate nerve palsy, whereas elbow arthroscopy, although posterior medial portals are usually not recommended and are not used, even with standard posterior portals, they can lead to an ulnar nerve iatrogenic injury. In wrist arthroscopy, the dorsosensory branch is at risk. In arthroplasty, ulnar nerve is rarely a complication, whereas a complication of the ulnar nerve can be found during ligament reconstruction of the medial elbow. The most common complication is when we are dealing with pediatric supracondylar fractures with cross-pinning, where up to 4% of patients may sustain an iatrogenic ulnar nerve palsy. Also, when we are dealing with fracture fixation, open reduction and fracture fixation, the incidence of late ulnar neuropathy can go up to 38%, and intraoperative management varies widely and can include in-site decompression or anterior transposition. What is interesting is that the percentages of these injuries and nerve dysfunction raise from the acute stage to higher percentages at the final follow-up. Also, complications from fracture repair have been described from fifth metacarpal fracture repair with subcutaneous K-wires. Finally, most common site of injury is during carpal tunnel release from the wrong side incision and the distal advancement of the instruments, and in general, the longitudinal primary incision can avoid these injuries. If we want to compare upper versus endoscopic carpal tunneling, it seems that although endoscopic carpal tunneling can lead to a transient nerve injury, both procedures, upper or endoscopic, have the same almost percentages of major nerve injuries. These are two cases where the patients had roadside surgery. In both cases, the yawn scanner was opened, was released instead of carpal tunnel. In both cases, the ulnar nerve was injured. In the first case, we had to have a revision of the release, aneurolysis, and adenolysis. In the second case, we had to open, of course, the carpal tunnel, the transverse carpal ligament, and then go on with a neurolysis and the vein wrapping technique. To proceed with the malpractice claims, once again, in this study from the general anesthesia malpractice claims, 12% were recorded of peripheral nerve injuries, with 2/3 of them being the brachial plexus and the ulnar nerves. And in another study in the United States, it was found that nerve injury was the predominant cause of litigation. Finally, prevention. Most cases are preventable by adequate knowledge of surgical anatomy, by awareness of the types of procedures in which peripheral nerves are particularly vulnerable, by the visual identification of the at-risk nerves during the procedure, by the expertise of the surgeon, by optimizing the positioning, and by using intraoperative monitoring. Thank you very much.
Thank you. So next up, Lada Papadogiorgou is up. Okay, so we heard about results being worse with proximal lesions and better with distal lesions. How much better or worse are they? Lada took the task of actually telling us what we're exactly doing with these injuries.
So good evening. It's a great pleasure and honor, of course, to be here with you today. When we are talking about the way we're going to deal with a case of ours that is supposed to be so difficult, and it is when ulnar nerve is concerned, then we have from time to time to sit back and have a look at the results globally in order to guide our treatment. So what are the results of ulnar nerve repair and reconstruction? We all have heard all the very interesting talks about the anatomy and the different levels of injury. Also, we all know that the difference of the ulnar nerve is that it innervates the intrinsics of the hand, which are really hard to deal with when the ulnar nerve is injured. I suppose that you have seen cases like this, which are disastrous. This is a case where an ulnar artery laceration was ligated together with the ulnar nerve, and the patient came really late to seek treatment. So, how can we obtain successful outcomes, and what do we mean by that? Successful outcomes are when we can obtain M4 strength and S4 sensation. Anything less is not a good outcome for the ulnar nerve. We should always remember that function can improve for up to 5 years following repair, partly because of the continuing nerve regeneration and innervation, and because of the psychological adaptation to the new patterns of innervation. We always have to think about the brain. Worse do the more proximal injuries where repairs requiring nerve graft or some kind of bridging, and those done in a delayed fashion. If we have a look at the big literature, then in this meta-analysis of 23 publications, they found that the ulnar nerve injuries gave a 71% lower chance of motor recovery than median nerve injuries. Also, another very interesting paper that studied the outcomes of 654 ulnar nerve lesions showed that finally the type of surgery is another thing that matters, because when we only need to do a neurolysis, then the patient will do better than if we have to do a primary repair, and then this is going to be better if we have to bridge a gap, a defect with nerve grafts or anything else. And of course, fewer grade 4 or 5 recoveries were reached than those seen in patients with any other nerve, next nerve, I mean radial or median nerves. In a paper that came from Greece, they actually wanted to see the outcomes of median and ulnar nerve repairs for sensory and motor recoveries. And they found out that besides the nerve, also the age, the level of injury, and the concomitant injuries play a major role in the results. Age is really important. And it's really important even if we're talking about the children versus adolescents. In this paper that studied the 30-year outcomes of median and ulnar nerve repairs performed in children and adolescents, they showed that the recovery was significantly better in those who had injuries in childhood. And well, the difference is huge, as you can see. It's 87% versus 67%. And this happened probably because of the shorter recovery distance, the accelerated nerve growth of children, and the increased brain plasticity. Of course, we always have to use sensory re-education and hand therapy to maximize the results. And as far as return to work and the satisfaction of the patients is concerned, then we have to remember that there are other personal factors that have to do with the patient himself. For example, the higher education status, the compliance with therapy, distal injuries, better post-operative grip and print strength that can be dependent on hand therapy as well, matter a lot. So it's not only the surgery, it's everything that goes after that as well. Now, how about reconstruction? And by that word, we mean the bridging of some defect. We know that we can use autografts, conduits, or allografts in order to do that. But, okay, autografts is the golden standard. But now we have processed nerve allografts, which are human nerve allografts. Also, we can use conduits like autologous tissue, veins, muscles, or endogenous materials, or natural occurring biomaterials, or synthetic biomaterials. All of that. As we know, nerve autografts is the gold standard, as I said, and it's the best option that we have. But how about using something else? When we say processed nerve allografts, we mean that these allografts are actually decellularized in order to reduce the immunogenic reactions, so they don't have any cells in them. And the problem is that there is a paucity of randomized controlled trials and comparative studies, and all those that we have come from the Ranger registry. And this is an injury-sponsored registry, and the injury that sponsored it is, of course, Axogen Corporation, the only company worldwide that produces this material. So maybe we could be talking about a bias concerning the results. Nevertheless, all the papers that have been published lately, they come to the conclusion that the outcomes compare favorably with those reported in the literature for nerve autograft, and they exceed those reported for tube conduits. Meaning that if we have a nerve graft that can be up to 70 millimeters, we can use nerve allografts. But then there is the issue of the cost, again, which is higher and so on. These can also be used if we need to address something, another problem like pain, and in general, they could be used for a wide range of applications. Current research supports the use of PNAs in order to, in order to bridge nerve gaps of digital nerves up to 1 centimeter and of motor or sensory nerve up to 30 millimeters. And now, the last thing that we use is nerve conduits. Of course, there are a lot of studies about conduits, and up to this study, I found interesting. They compared 33 studies in 1,531 cases, and they showed that sensory nerves were found to achieve a more satisfactory recovery than motor nerve. Median did better than ulnar nerve, as always, and there was no statistical difference between tubulization and autologous nerve graft in repairing defects less than 5 centimeters. I found this really interesting. I'm not so sure that it's valid though. Nevertheless, tubulization with any kind of conduit could be a good alternative in the reconstruction of small defects. In the literature, there's a great deal of publications, though, that they mention the limitations of nerve repair of defects, any defects, with acellular conduits that don't have the same properties, of course. I'm not going to talk about nerve transfers, just to mention, in order to attach my presentation with the next speakers, that all the recent papers mention nerve transfers because they have been used widely after the first publication from McKinnon and colleagues, that they have termed them supercharged end-to-side nerve transfers, and they need to address a problem with innervation of intrinsic muscles. But Nikos Dallis is going to tell you everything about those. So in conclusion, the functional outcomes after ulnar nerve injuries are really difficult to achieve, mainly because of the intrinsic muscle function. Factors influencing outcome besides the type of nerve include age, the level of injury, other injuries, and the length of the nerve gap, of course. While the data on usage of the PNAs, the allografts, continues to grow, and ongoing research into better nerve conduits appear promising, the autograft is still the gold standard. Full recovery of this specific nerve may take up to 5 years, so don't be hasty to judge your outcomes. And then distal nerve transfers are also an option, as well as tendon transfers, of course. Thank you very much from Mr. Picture from my beautiful town, Thessaloniki.
Okay, eventually I'm the last speaker because the last speaker, for those of you who came in late, is done with the coronavirus. So, I'll be discussing peripheral nerve transfers, and when you're faced with a proximal ulnar nerve injury, you have to ask yourself, are my actions going to reach the small muscles in the hand in time? And more often than not, this is not going to happen. Your actions will arrive too late, and you will not get any function because they'll arrive to scarred muscles. And as you heard before, additional negative prognostic factors are delayed presentation, an extensive injury zone, or a nerve defect that needs nerve graft. So, what's the solution? The solution is to shorten the distance that your actions need to travel to. And this is done with nerve transfers, and there's a track record from the brachial plexus for this. The first publications were not actually from the United States, they were from China, and after that from Italy, from Battistone, and lastly from McKinnon. And what they described was a transfer, an end-to-end transfer of the anterior interosseous branch to the pronator quadratus to the motor branch of the ulnar nerve. Basically, an iatrogenic nerve, ulnar to medial to ulnar nerve communication. And it was originally described as an end-to-end transfer, but then McKinnon revived the concept of end-to-side nerve repair, which was actually very controversial. And it applied it to the same transfer by doing an end-to-side transfer of the anterior interosseous to the ulnar motor branch to babysit the muscle, so to speak. And actually, it gave the procedure a very good name. It called it supercharging, which is great because everybody wants his nerve supercharged. What are the indications? Obviously, all the negative prognostic factors that I mentioned before, and it can be done in conjunction with primary repair or grafting. What's interesting is the contraindication. You cannot do it if the muscles are atrophied and you have glowing, or better still, you should see your EMG, and if you don't see fibrillations or positive sharp waves on your EMG, you because these are both signs of denervation, but also signs of viability of muscle fibers. If you have a silent EMG, then you cannot do the procedure. What's the time frame? Usually it's 3 to 6 months after injury for the motor part of the procedure. For the sensory part, you can go further down the line. Can you do it in the acute setting? Yes, you can, but in the acute setting, it is sometimes difficult to tell what the zone of injury is. And as you heard from Dr. Zagoreas, you might already have a median to ulnar communication, which means that it's not necessary to do it. So if you're not sure, you might want to delay that in the subacute setting. How about chronic lesions? Decisions in chronic lesions may be straightforward, but sometimes they can be very difficult, especially in neuronal continuity. You should consider your pre-op EMG, your intraop nerve simulation, and lately the intraop nerve monitoring has become a tool to help us make decisions there. How do you do it? Your donor is the anterior interosseous pronator quadratus, so you have to, this is how it looks in the OR, so you have to actually dissect the nerve into the pronator quadratus so that you get some length. And then you have to prepare your recipient, which is the motor branch of the ulnar nerve, as I was described very well. It's sandwiched between the sensory branches. You can follow it back from Guillon's. You need to neuralize the nerve to actually get in the middle motor fibers for this transfer. This is how it looks in the OR. This is a proximal ulnar nerve lesion with long nerve grafts. This is not going to go down well as intrinsic function is concerned. So at the distal forearm, on the upper part of the screen, the sensory part of the ulnar nerve, and on the lower, the dorsal sensory branch. And in between them, the one that we're cutting is the motor fascicles, the motor part of the ulnar nerve. And we will be, anastomosis will be connecting that to the anterior interosseous. This is the anterior interosseous, and as you can see, there's not a great mismatch between these two nerves. All you need is a couple of sutures and some fibrin glue, and this is how it looks completed. If you need to do an end to side, what you'll do is you do an epidural window, put a couple of stitches, and then take all your fascicles and just tuck them into that epidural window. Sensory transfers, we don't need to do them that often. Patients don't ask for them, basically. You can either go for the classic McKinnon transfer, which is from the trunk of the median nerve, either end-to-end or with allografts, or we prefer not to mess too much with the trunk of the median nerve. We prefer to go to the periphery and either get digital nerves or the volar branch of the median nerve for these transfers, and this is how they look in the OR. So what's the downside? The downside is that you're giving the ulnar nerve approximately 1/3 of the actions that it actually has. But it has been proven in the literature that that is enough to prevent clawing. Study after study, and recently in a systematic review, 75 to 85% of the patients recovered over M3 plus intrinsic muscle strength with minimal complication, which is great. Should you do end-to-end or end-to-side? Even though results in the literature are comparable, the more unlikely the recovery is, we opt for end-to-end because of the better track record that there is to it. This one is our younger patient. He's 10 years old, 14 months out of his surgery. As you can see, he still has some small finger escape, but however, he has quite strong muscles. You should keep in mind that these people keep improving over 2 or 3 years, so he's somewhere early down the line. This is our oldest patient. He's 60 years old. He's 4 years out of his surgery. And I bet you cannot tell which hand is operated. Actually, it's the right one. And these both examples are end-to-end transfers. So they actually can do very well. You have to know direct repair, you have to do nerve grafts, and you have to do nerve transfers. If you want to treat an ulnar patient with an ulnar nerve injury, you have to know all your weapons. Thank you.